Please listen carefully.
Hello, Team Anaesthesia. Welcome to GasGasGas. This is the best anaesthetic science podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. Now, you might be in the gym right now, commuting, or ironing your scrubs, and there's no judgment here. GasGasGas will prime your brain for the monsoon of knowledge you need to imbibe. But regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Now remember to check out the website, that's gasgasgas.uk. There are show notes there with all the detail, plus links to foundational reference papers and anything else useful I find for you guys. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show.
This is a unexpectedly sultry late night intro and outro recording as everyone else has gone to bed. Here we have another episode of Gas Gas Gas. Today we are taking Shyam through his paces with questions on aging, neuroprotective ventilation, endotracheal tubes, and managing lasers in theatre. Now remember, if you're preparing for this oral exam, being able to talk the talk is as important as being able to actually convey the knowledge you know. Structure that can be applied to multiple different questions is really important. A, B, C, D, E approach. Pre-op, intra-op, post-op, breaking intra-op down into induction, maintenance, and emergence. Having immediate, early, and late complications. Think up what works for you, try to apply them dynamically, and get that practice in. Anyhow, let's get on with the show.
Lots of physiology. You ready?
Lots of physiology. Yeah, I'm ready. Yeah.
Aging is unfortunately going to happen to all of us. How does aging influence the various systems in the body, and how does that influence your anaesthetic practice?
Sure. So aging essentially can influence our body multiple ways. So I like to think about this in an AQE approach because that's what we'll probably do as anaesthetists. So thinking about the airway and the respiratory system firstly. So starting with the teeth, you're likely to lose teeth as you grow older. This will make you edentulous at that time. So this may make, as an anaesthetist specifically, for us, it might make bag vas ventilation quite difficult for us. We may need to use adjuncts in that way, or etc. Secondly, in terms of positioning of the airway due to C-spine immobilization, that might make laryngoscopy quite difficult as well, due to acquired diseases such as osteoarthritis or rheumatoid arthritis. Moving on to the respiratory system. So as we grow older, the first thing that changes, our lungs lose elastic tissue. So this increases the compliance of the lung. So for the same pressure changes, you may generate more volumes. I've certainly definitely experienced that firsthand when bagging someone who's of elderly age. And secondly, you're more likely to, or your closing capacity starts exceeding or encroaching on your FRC. So at 65, when you're standing, they're about the same. So you're likely to get small airway closure more likely to occur. And secondly, you're more likely to have emphysematous lungs as well. So while this may increase your FRC, it's essentially not going to give a good gas exchange. So you may have more VQ mismatch and shunt present as you're getting older as well. So that's something to think about. So secondly, in terms of the cardiovascular system, so the main thing is the arm-brain circulation time increases. So the effect that you may see with your induction drugs may be prolonged. So this may, firstly, two things may occur. You may give too much because you're not seeing the effect that you want, and then that might cause a rebound hemodynamic instability that occurs. And secondly, the elderly population, they have more stiffer arteries, so they're not able to diastolic recoil, which is important for perfusion. It's called the Wind-Kessel effect, which may be reduced, and this may also be quite detrimental to the heart. Thirdly, they're more likely to have valvular issues, poor myocardium secondary to previous MIs, etc., or so they're more at risk of having a myocardial event from distress that's occurring. And secondly, they're more at risk of, depending on the valvular issues, of cardiovascular collapse. So thinking about the metabolic side of things, so the physiological reserve for the elderly population may be reduced. So this may mean that they may not mount enough of a stress response, and this can be quite detrimental to them in terms of their healing factor, in terms of their ability to maintain and nutritionally heal themselves. So this may lead to prolonged admission, prolonged ability in when we give anaesthetics to them. In terms of the other things as well, so firstly, they're more likely to have renal issues and renal problems. So their clearance of drugs may be reduced. They may be also taking a lot of different medications, which may induce liver enzymes or inhibit liver enzymes, which may manipulate the metabolism of the drugs that we're giving and using. And in terms of the CNS effects as well, so firstly, as we grow older with volatile anaesthetics, the MAC reduces, so we don't need to give as much for them. But secondly, they're more likely to have cognitive impairment. So they're more at risk of post-operative delirium as a sequelae of being under sedation and the residual effects of our drugs as well. And thirdly, an important one is due to their reduced subcutaneous fat and also reduced hypothalamic maintenance, there may be poor thermoregulators, so they're likely to lose heat very quickly. So it's important that we keep warming and think about that in the elderly population.
And how might you approach post-operative cognitive delirium? How would you seek to reduce the risk of that?
So it's all about pre-op, intra-op and post-op. So a thorough pre-assessment is important, looking at what they take, what are their medications, is there any evidence of cognitive impairment, and taking a detailed history in that point of view can then allow you to think about your anaesthetic plan. So, for example, if it's suitable or able, a spinal anaesthetic where you're reducing the opiates or regional anaesthesia, if amenable or cooperative, would mean that the less systemic effects are likely to occur, and this can be then avoided. And secondly, ensuring that you minimize opiate use, thinking about certain drugs like atropine, they can cross the blood-brain barrier. So if you need to think about manipulating heart rate, that can also be a sequelae of that as well. And again, ensuring normal everything. So normal tension for the patient, normal oxygen, normal glycemia, and these are all effects which will, and normothermia will help reduce the impact of post-op delirium in these patients.
Excellent. And that is your time there. Okay. So, do you need a drink or anything? Are you good?
My water's just here. I'm going to just grab it in 2 seconds. Got it here.
Yeah. You happy?
Thank you.
Yeah, cracking. So, describe your approach to neuroprotective ventilation.
Sure. So, the whole aim of neuroprotective ventilation is to essentially avoid secondary brain injury. And that is essentially because whatever the insult is, we want to make sure that we protect the brain as much as possible so that we can maintain good neurosurgical outcomes. So my approach, I would start with airway. So obviously we want to protect the airway, endotracheal tube, but the nuances of that is, firstly, we don't want to tie the tube in. We probably want to use like sort of stick face or something like that, or tape, to ensure that because this will repair the venous drainage to the brain. In terms of the venous drainage of the brain, sorry. In terms of ventilation, so minimal tidal volume, so 6 mils per kilo is always something that I usually go for. Maintaining normoxia, so a PO2 again above 8 to 10, that's what I'd go for, and PaCO2 of around 4.5 to 5 kilopascals. So I would reduce my PEEP as much as I possibly can. So try and keep it less, or 5 or less, as my PEEP is what I'd aim for. And these will essentially, the reason is the more PEEP that you are having, the less venous return that you're going to get from your brain. So this can increase your ICP at that time. So these would be sort of, and I'd maintain normoxia, normocapnia, and these are the neuroprotective ventilations. Do you want me to go to other things as well? Neuroprotection in general? Or?
Yeah, so what other important things must you achieve to protect that brain?
So So in terms of positioning, as I said, so 30 degrees head up, that would again help with venous drainage. Now, cardiovascular, it's very important that we maintain a higher MAP, because in the brain injured patient, they would lose their cerebral autoregulation. So the MAP, it depends on what the underlying pathology is and what your systolic you're aiming for. Usually the systolic's around 110 and the MAP around 90 is what I've read and aimed for in my practice, 80 to 90. So this may require the insertion of an arterial line, and also maybe peripheral vasopressors to ensure that this occurs. So that's the cardiovascular side of things. In terms of disability, so normoglycemia is very important. So this may require the use of glucose infusions or variable rate insulin. That's one thing as well. And secondly, temperature. So temperature control is very important as well. So normothermia, so aiming for a temperature of at least 36 or above for your implied amount of time as well.
Okay, excellent. And so it sounds like you're alluding to the goals of maintaining cerebral perfusion pressure.
Yes.
What governs cerebral perfusion pressure?
So cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure or your CVP, whichever one is higher. And so any of the factors which affect this will affect your cerebral perfusion pressure. So MAP, we've sort of alluded to, so that would be cardiac output, heart rate, stroke volume, etc. So those are the things we can move to one side. Cerebral perfusion pressure is important in terms of the ICP. So that's governed by your Monroe-Kelly doctrine, which states that your head is a fixed space, your brain. So if there is an intracranial pressure or raise from blood, certain things first move out. So you've got your CSF, which moves out. And then if that starts to decompensate, then you might have herniation of brain tissue, which is not where you want to go. But at that point is where you would, so that's what we can use to govern it.
Excellent. So we talked about achieving oxygen delivery to the brain tissues. How could we reduce the oxygen requirements of those tissues?
So you can reduce the cerebral metabolic requirement of oxygen due to a number of ways. So firstly, sedation. It will do so. Propofol and alfentanil is something that we use quite commonly. So, for example, propofol will reduce your intracranial blood flow and your TMRO2. So that's one way that we can try and reduce that. Other medications, so if they are having a lot of seizures which are uncontrolled, then you may need to think about reducing that even further with the use of anti-epileptic drugs. So, for example, first-line pentone may be another drug that you might need to infuse to try and stop those seizures.
Mm-hmm. Okay. And how else would you optimize the delivery of oxygen to the brain tissue?
Sure. So the delivery of oxygen to brain tissue is essentially governed by the cardiac output and also the hemoglobin that's present as well. So obviously the oxygen content in the blood is important. So ensuring we have no anemia. So if there is a loss of blood in the brain, may want to transfuse them. If the HB is low, to correct any anemia at that time, and ensure that our cardiac output is maintained. Hence why we try and aim for a higher MAP as well, because that will also help with our oxygen delivery.
That is 5 minutes. Have a cough if you need to. I know you're desperately trying to suppress it.
Yeah. Sorry.
No, don't be sorry. It's fine. So that's everything I've got for physiology. Just going through your targets for your neuroprotective and ventilatory anaesthetic strategy approach. They would generally say target a PaO2 of greater than 13.
Okay, PaO2 of greater than 13. Yes, fine. 13.3.
This is because a margin of safety, really. Inadvertent desaturation because the patient's coughing because the paralysis is worn off.
Paralysis as well, yes.
The brain's really sensitive to that. Yeah. The CO2 target, I think when you said blood pressure, what was your blood pressure target again?
So my MAP was 90.
Yep.
And so it depends, because, so for example, for subarachnoid, I think it said 110 to 150, your systolic.
Yeah.
Yeah. Yeah, so I would just remember seeing the little graphs of where you want your maps to be on the Yorkshire transfer thing. So that's what I was trying to remember. Because I had to use it the other day. I was like, oh, okay.
Yeah. So I would, in the exam, just quote that you need a map target that it counters any intracranial pressure. 90 millimeters of mercury is what I would aim for. And if they ask you to drill down about, it'd be really weird for them to be like, so, but what about when it's a subarach? Because that's quite nuanced, and actually they have a brain full of blood. They've got hydrocephalus. It would be lovely to have a systolic less than 150, but if that means you can only get a map of 75 out of them, then are you doing their brain a disservice? So it's challenging. So I'll just stick with 90 millimeters of mercury.
The map of 90, fine. Yeah, I will remember. Yeah, okay.
Yeah, and just don't give them the opportunity to be like, yes, but why did you say this? And then make your life harder. And then in terms of Monro-Kelly, absolutely, brain is a fixed box containing CSF, venous, arterial, and brain tissue. But remember that if you've displaced your CSF as a compensatory measure, you will then displace your venous blood as a compensatory measure, and then arterial blood, and then brain tissue, as like a scale of what can not get in the brain or what can be squeezed out of the brain first. Those are all the things I had. I like your systematic approach to ventilation, like airway ventilation, justifying why you were doing things as you went. But when you get into the maintained cerebral perfusion pressure area, you could overarch this, like you said, preventing secondary brain injury by ensuring adequate oxygen delivery and a reduction in oxygen demand of that tissue. Because these patients, you just want to get them as deeply anaesthetized as you can. And you will invariably need metaraminol to maintain that map of 90, because you need to be on a ton of propofol. Anyhow, time for a brief mention about the sponsors of GasGasGas, Teach Me Anaesthetics. These guys are behind an excellent single best answer question resource. Firstly, I took the joyful, challenging, and intermittent bashing through their 1100 plus questions, which they have written for the FRCA primary exam. Now, I secretly loved it, and there are plenty of questions to test your knowledge. When I was studying for the FRCA primary, it did not exist, but there were other packages online. These cost a lot more, and they didn't really seem to reflect the content of the exam. Whilst doing them, I came across rehashed MRCP questions, which was not terribly inspiring and left me pretty cheesed off. Whereas these single best answer questions have been built from the ground up. They have not sniffed an MCQ in a past life. They are based on the anaesthetic science you need to know, and there are explainers with all the questions, so it builds your knowledge as you work through them. There is a multitude of ways you can study these questions. You could choose to do a random battle with 1100 plus questions, or split them into subject area. You can go back and redo the ones you've gotten wrong. It's very malleable. So if you've been thinking about which question resource you might want to get your hands on for the exam, you shouldn't really look any further than Teach Me Anaesthetics. If you reckon it's for you, all the links to Teach Me Anaesthetics from GasGasGas are affiliate links. So if you're signing up through one of those, you're helping to support GasGasGas. So if you think you're going to go for it, click a link with me. You know you want to. You'll not only be supporting your exam preparation, but you'll be supporting your 100% favourite Tell Your Nan Over Sunday Lunch podcast, which is, of course, GasGasGas. Yeah, cool.
Physics time, yeah, let's go.
Okay, moving on. Physics time? Let's see.
Right, let me get one more cough out and then we're...
Yeah, sure. Okay. Ready for action?
Yeah.
So, Shyam, this is your physics Viva. Well, physics and equipment, I should say. Talk me through the different endotracheal tubes you have at your disposal as an anaesthetist.
Sure. So you have your standard endotracheal tube that they have the internal diameter, so 6.5, 7. They also then have certain parts that they're made of. So they're usually made of inert plastic so that they don't react with anything. They usually have a cuff that's present, so which is usually a low pressure, high volume cuff, so that it doesn't cause any stenosis around the trachea, which you usually inflate with about 10 mils of air. In terms of for guidance in placement, there's usually a left-sided bevel, so you can see it pass through the cord. Murphy's eye, which also means that if the entrance is blocked with secretions, there is still a way to bypass that and deliver your gas flows that are present. And also there is usually two black lines which guide where the vocal cords need to sit. And then there are centimetre demarkings to allow you to gauge depth of insertion. So that's your standard endotracheal tube. Now you may have different versions of this. So firstly, you may have a Ringer Ray tube, so RAE tube. The abbreviation escapes me, and there's two ways for which you can have ones that are just south facing. So this is in essence to try and access where it's shared airway surgery. So main indications that I'm familiar with is for tonsillectomies and tonsil surgeries. So this is south facing, so it can be accessed by the surgeon as well as the anaesthetist. And the issue with that is what may stop you from putting the tube in too far is the fact that it curves with the lips, so you may inadvertently you may have issues with your depth perception with that. Then you have north-facing tubes, so these are usually your nasal endotracheal tubes. So they're usually it's quite hard to show this without drawing, but essentially they're shaped like that, which you can then put through the nose, and it sort of follows the curvature of your hard palate to allow guidance through there. So again, this would be mainly again for preference in shared airway surgery, maybe either mouth surgery where you need all oral cavity, max fax cases potentially. And then you have reinforced and laser protective endotracheal tubes as well. So these would be for where laser is used in airway surgery or mouth surgery, or for example, they can have EMG in it to detect recurrent laryngeal nerve activity as well. And this can be used in thyroid surgery as well. And I can't think of anything else in terms of endotracheal tubes. At this point in time.
Sure. What about tubes on intensive care?
Oh, yes, of course. So tubes on intensive care usually, so they have a supraglottic port, which allow for aspiration and suction of the above the cuff to allow for, to ensure there's no inadvertent leakage and to reduce the risk of VAP. In terms of, so there's the supraglottic port present there. They're also slightly made up more, less malleable plastic, as they are likely to be present for a longer period of time. And they usually are slightly more reinforced than the ones that we'd use in theatre. So they're the main differences.
Okay. And what tube might you reach for if you need to do some sort of vocal cord intervention?
Would it be a small microtube or a laryngeal? Yeah, so a laryngeal. So yeah, a microtube, that would be quite a small one that you'd need to use because they may need access to the airway, so you'd need to be able to quickly manipulate the tube position as required.
Absolutely. So you mentioned tubes for laser surgery. Could you talk me through a laser appropriate tube in more detail?
Sure. So a laser appropriate tube essentially serves two functions. One, it minimises the risk of a laser airway fire, and two, if it were to occur, if there was some issues with it, you'd be able to identify it quickly. So firstly, talking about the aforementioned protective measures, so it's usually covered in a reflective sort of shielding. That shields from the laser to ensure that it doesn't reflect in either ways and can ignite the tissues that are present there. And also it's usually got double cuff, which one of the cuffs is filled with saline. So if there was cuff rupture, you can then see saline start douching the airway, and that might start the process of how you would deal with an airway fire, or that might be an indication that the cuff has ruptured. You may need to change the tube.
Okay. So moving a bit further into lasers and airways, how would you manage the safety of the patient and the team during surgery with a laser?
Sure, the safety of the patient, firstly, is using a laser enforced tube, that's one thing. Essentially, secondly, minimizing the amount of oxygen you're giving to the patient. So obviously you want to oxygenate them, but the lowest possible oxygen you require to sufficiently do and safely do so. That's the main thing. Thirdly, it's important that you discuss with the surgeon that, okay, make sure that they don't inadvertently keep switching the laser on. Make sure you take away all the oxidizing agents and the igniting things that can be present at that time. In terms of how to protect the staff, so you'd have in the theatre black reflective shields that that absorb the laser so it doesn't reflect everywhere. The theatre staff will wear specific eye goggles, which are attuned to take out the specific wavelength of the laser you're using, so it doesn't cause harm to them as well. And so those are the main ways in which lasers can be minimised.
Any way of stopping staff not wearing goggles entering theatre?
Oh, so of course, outside the theatre, you'll have a laser saying "laser on. Please do not enter without appropriate equipment, or just don't enter in general." So you minimise the amount of staff that's present there. So the less staff that's present, the less likely chance you're to get injury or anything as well. So that's another way.
Would you use nitrous oxide?
So nitrous oxide in itself is igniting. It can be oxidized, especially by laser. So I wouldn't use nitrous oxide.
Unfortunately, for some unusual reason, your trainee has been using ether and a nitrous oxide mix, and there's been an airway fire. What's your approach to managing this?
So I would call for help. I would declare a critical incident. I would tell the surgeon to stop the laser straight away and pull the buzzer. I would remove the airway device, bag mass ventilate with 21% oxygen, and douche the airway with saline. So that I would then, next steps would mean I would call my boss and see if we need to firstly bronchoscope the patient to see if we've got any inhalational issues or anything further that would preclude us waking this patient up, and then replace the airway with appropriate endotracheal tube, and if needs be, postpone the surgery until we can get further safety. But this would be a decision taken by my senior.
Excellent. Yeah, okay, lovely. We'll call that time on that one. How do you feel about your tubes? You say you a nice approach to tubes. The only thing you did do is quickly gloss over laser tubes. You went, oh, and laser tubes, and moving on.
It's because I've not seen one.
Yeah,
So it's I need to look at them, to be fair. So yeah, but that's fine. I should have probably gone into. So yeah, I just thought. To be fair, it's not a question I've done, but it's a question. But I felt like I tackled that with grace and not to get flustered by it.
I liked the that you just defined a bog standard tube first, and then that allows you to naturally explain other things. With a laser tube, I'm pretty sure they fill both cuffs with saline. And yes, perforating a cuff with laser does fill the airway with saline, which is a benefit, but also the specific heat capacity of water is much higher, so it takes quite a lot more energy to pop the cuff as well, because it absorbs some heat first. The other thing, protecting the patient. You mentioned the tube choice, the gas choice, but the patient has eyes as well.
Oh yes, of course. The patient needs to wear goggles as well.
Yeah, patient goggles or gauze, etc. And generally, most gauze that's being used in the airway is saline soaked, so it can't ignite. And the scrub nurse has a bucket of water to throw at the surgeon or the patient, probably the patient. They have a jug of saline or sterile water to slosh in the airway.
Standby. Yeah. Okay, that's good to know. Yeah.
So they'll slosh saline in the airway, wait, because you don't want to pull out a half molten tube and take some trachea with it. So you put out the fire, let it cool slightly, and then pull the tube, is the general approach. But yeah, and you stop ventilating. And yeah, so laser safety, break it down into like defending the patient, putting fires out, and defending the staff.
Sounds good, yeah.
And yeah, microlaryngoscopy tubes. Long, still have a cuff, high resistance because they're long and narrow, and they're quite floppy, so they're quite awkward to sight. So often a bougie or a stylet is necessary. And lastly, double lumen tubes for cardiac, for thoracic surgery. Yeah.
Of course. Oh, yes. I knew I forgot one. I knew I had that feeling. I'm definitely forgetting one here. But yeah.
I don't think the examiners are going to shoot you if you forget one type of endotracheal tube. They may prompt you to ask you about dual lumen tubes. It'd be really weird to be asked about how to site a dual lumen tube in the primary FRCA. Broadly speaking, you need to confirm that you ventilate both lungs. You do so independently with the cuffs up and down, and use a bronchoscope to prove that you are in each main bronchus and that your cuffs are not occluding the right upper lobe bronchi on either side, noting that it's much easier to occlude the right upper lobe bronchus than the left upper lobe bronchus. That's more of a final FRCA question, so don't worry too much about it. So thank you very much for listening. Again, a sultry outro courtesy of everyone else going to bed. See you next time, where we are doing metaraminal.
Ahoy, Team Anaesthesia! You've survived yet another episode of Gas, Gas, Gas. Now, if you found it useful or harrowingly awful, please like and subscribe, drop us a star or 12, and follow with whichever podcast platform you find yourself using. Please leave a comment or ping off an email if you think I need to square something away. Now, there are a bunch of ways to support the costs of Gas, Gas, Gas. From buying me a coffee, to venturing forth via an affiliate link, to the horde of joyful SBA questions from Teach Me Anaesthetics. Those links are on the website and in the show notes. Speaking of website, definitely check out GasGasGas.uk for the show notes, diagrams, details, the references. Now, we all know, guys, that this is a bucket of content to consume, and it is like drinking from a fire hose. So I want to finish by saying, take it day by day, don't overcook yourself, don't freak out, and keep studying.